Thank you for Professor Nellen's introduction. Now I shall share my PPT. Can see my the PPT.
Yes.
Okay.
Yes, absolutely. Yeah. Very nice.
Thank you. Thank you. Good afternoon in London and the night in East Asia. And I'm from China, Huashan Hospital. My topic is another kind of hydrocephalus, low pressure hydrocephalus in patients with disorders of consciousness. Hydrocephalus is very common in neurosurgery. Most of the hydrocephalus is very easy, but some hydrocephalus patients is difficult, very complicated. This is a case of female patient, 6 years old, suffer from the aneurysm rupture and secondary hemorrhage. The patient survived with the unresponsive fullness syndrome, vegetable state, without consciousness for 5 months. The CT scans show the ventricle size a little enlarged. I believe some neurosurgeon will choose to operate, and other neurosurgeon must be choose not to operate. This is difficult to decide which one is the best. First, we should make clear what is the definition of the hydrocephalus. Hydrocephalus is a disease caused by the excessive cerebral spinal fluid in the ventricle, which oppress the brain tissue, even leading to symptom and damage and investment to the brain function. The key point is excessive CSF volume, no matter of the pressure. Maybe the pressure can be high, can be normal, can be low, even can be negative. Yeah. For the classification of hydrocephalus, most famous classification is Dandy classifying into communicating and obstructive hydrocephalus in the 1914. But as we know, almost all hydrocephalus are obstructive. Actually, it is just the location of the blockage is different. But clinical, we have various kind of hydrocephalus. Yeah, such as the acute cerebral hemorrhage. This is the acute hydrocephalus. This patient will have a high pressure. This kind of patient, emergency EVD is very necessary. For the NPH, normal pressure hydrocephalus mostly happen in the elder patients, showing the events index more than 0.3, and carousel angle can be smaller. Also, we also can see the cingulate sign and dash sign. This is a very special kind of hydrocephalus, and pay more attention for our neurosurgeon. The secondary is the low pressure hydrocephalus. The CT scan different from others. Yeah, this kind of hydrocephalus mostly happen in patients with older consciousness. Usually for the patients that from the chronic CNS infection. So in this kind of hydrocephalus, they have different pathophysiological characteristic and need different strategy to treat this hydrocephalus. So we make classification for the hydrocephalus according to the ventricle pressure. This is very easy, and more than 200 is high pressure, and 70 to 200 is normal pressure, and 0 to 70 is a low pressure, and below 0 is negative. Because this different pressure level means different pathophysiological condition and different strategy and treatment measures. Especially for the negative hydrocephalus, if you have high high infection, CNS infection rates, and high mortality. And so we released this clinical patient in 2019 in the neurosurgery, and this image can show the obstructive point of the patient for different kind of hydrocephalus. Obstructive hydrocephalus usually blocked in the midbrain aqueduct. The communication hydrocephalus usually blocked in the alveolus granule, and the negative or low pressure hydrocephalus usually blocked in the median and the lateral foramen of the forceful ventricle. What is the high risk for low pressure hydrocephalus? And usually it's the hemorrhage or infection cause the disconnection between the ventricle and convex the subalveolar space, especially for chronic CNS infection and the posterior force operation and the intracranial and ventricular hemorrhage patients. How to diagnose the secondary low pressure hydrocephalus? The first patients have a history of severe TBI with the subalveolar hemorrhage in the ventricle, and especially the posterior cranial force operation, especially combined with the CNS infection, chronic CNS infection. All these patients show gradual clinical deterioration with the ventricle acromegaly developing and showing the same symptom as the routine hydrocephalus. But most important, the key point is for this patient is the ventral pressure below the 17 mm H2O, and all these patients CT scan have a very special characteristic. Besides the obviously ventriculomegaly, the subalveolar space in the convexity including Sylvian system almost disappear. For the fourth ventricle is very special. Will show enlarged, mostly can appearing as a sphere with tension. We can call the both sides just for the three dimension is like a bow. The brain tissue, the whole brain show the stiffness, indicating the decreased brain compliance. Ambient system and cranial system mostly remarkably reduced and almost blessing. So this means the subalveolar space is obstructed between the ventricle and the spinal cord. So this kind of low pressure hydrocephalus is mostly happened in the severely damaged patients. So it mostly happened in the patients with severely disordered consciousness. So we summarize this kind of hydrocephalus clinical character and treatment strategy, and released in Journal of Neurotrauma 2 months ago. And 68 patients enrolled. And we will find the VP shows the VP pressure setting 2.0 and 1.5 is normal pressure. 1.0 and 0.5 is low pressure. And the patient with low pressure have longer disease course than the patient with the normal pressure hydrocephalus. And in this group, says 68 patients, 41 patients. This means 60.3% patients present with the low pressure hydrocephalus. And this means low pressure hydrocephalus is very common in the patients with the severely disordered consciousness. So for these patients, we do a BB shunt before an operation and after operation. the consciousness level, that's a common scale, and this common recovery score improves significantly. GCS score increased from 7.9 to 10.7, and the CSR increased from the 5.7 to 13.885. And 92% of patients in this group show consciousness level increased significantly, and the portion of the portion of the MCS minimum conscious state patients increased after operation. In 2014, counts in the clinical neurology and the neurosurgery also found for the negative hydrocephalus, when the CSF drainage, the patient's glaucoma scale increased, compared with the ICP increased. Now we have 3 cases for this kind of patient. The first patient is the female, 24 years old. He is a primary school teacher who suffered the posterior force hemorrhage and survived 1 year, and then developed hydrocephalus and accepted BB shunt. 1 year later, so the patient is still in the UWS state without consciousness, and we find the ventricles still large. BB shunt assess 1.0 metronic BB shunt, and when we decreased the lowers to the 0.5, the ventricle still almost not changing, is still large. So we make EVD 300 milliliters a day for 10 days. The patient can follow the sound and turn ahead, show the minimal state. Obviously, the hydrocephalus cannot treat very well with this VB shunt to the lowest. So we changed the VB tube, because previously VB tube is anti-cellphone VB tube. So we change this with the non-anti-cellphone programmable VB shunt. 9 days later, this can show the ventricle becomes smaller obviously, and 1 year later, the patient recover conscious very well, can take care of herself in daily life. And this patient shows that the patient with severely old consciousness disorders have relative poor brain compliance. So we recommended to prefer non-anti-cellphone shunt tube over anti-cellphone shunt tube, VB tube. The second case is just come back to the go back to the beginning of the case. This is the 60-year-old. Yeah, after annual clipping and hemorrhage, the patient in UWS state, the vegetable just means the vegetable state without consciousness. The ventricle size is a little enlarged. So in our department, 5 months to our department is a huge argument. Yeah, so some neurosurgeons decided to VB shunt, but some denied to operation. What's more, the skin in the frontal local region is very thin and damaged. So we, after communicated with the relative very well and repeatedly, we decided to operation to cranioplasty and the VB shunt together. Yeah, well, because the skin very thin, so we take a tissue letter of the sign to cover on the planning plate. And VB shunt, we set the VB shunt to the lowest to the 0.5. Yeah, but the patient shows no improvement in consciousness level. The patient still in the vegetative state. So we still try our best. We try to EVD 100 milliliter a day, 200 milliliters a day, gradually increased to 400 milliliters a day. Yeah, nine days later, the patient can eye open upon the cooling. Obviously, the hydrocephalus not choose very well with the VB shunt to the lowest, but the EVD can work. How to do? Because so many foreign materials because so many foreign materials in the brain, such as titanium, VB tube, aneurysm clipping, and artificial meningers. So if the induction happened, this the patient will be fatal. Will have is imaginable. So we stopped the EVD. How to do next? And finally, we decide to punch the valve. And let the patient doctor punch the valve 500 times a day, and then increase to the 1,000, 2,000 a day. The CT scan showed after the patient punched 2,000 times a day, and 11 days later, the patient can follow order occasionally into the minimal conscious state. A CT scan showed the ventricles becomes slightly smaller. Okay, so but obviously the ventricle size still enlarged compared to normal size. So we increased to the 3,000, 4,000, 5,000, as last to the 6,000 times a day, almost 5 to 6 hours a day for the relative to punch the valve. Then after punch, yeah, the ventricle size, yes, becomes smaller. The patient conscious level increased. That the patient can walk, can take care, almost can take care of herself, can dancing. Yeah. So for this case, this image showed the different VB shunts pressure setting and the different times punched the VB shunt valve for 600 and 2,000 and 6,000 and different CT imaging and different conscious states. So this case showed for the low pressure hydrocephalus, if the shunt is still insufficient after conventional pressure regulation to the lowest, pressing the valve maybe a good choice. Third case is a male patient, 76 years old. The patient shows severely the aneurysm rupture, and we embolized the aneurysm and the EVD. The patient survived with the hydrocephalus and accepted the VB shunt. But this patient is negative high pressure because when the VB shunt valve is connected, there's no cerebral spinal fluid outflow at the external auditory canal level. So we try to improve the brain compliance and the ventricular pressure. The patient, but the patient cannot recover consciousness very well. 4 years later, the patient occasionally to our hospital because the previous patient's successful experience. So we tell these patients, doctor, to punch the VB valve 600 times a day, and the patient. The ventricle size, yeah, becomes smaller from the 67.8 mm to the 62.8. Becomes smaller. The patient consciousness improves significantly. It can communicate with her granddaughter. Yeah, this is 10 years later. The patient recovered very well. This case shows for the super elderly patient with vegetable state combined with hydrocephalus, we should not give up and can strive for precise treatment of the hydrocephalus. We should still have the possibility of weakening the patient. So for the hydrocephalus with the patient in disordered consciousness, we should know understand the patient's history and the symptom detail, especially the change, and the detailed radiology examination, such as the CSF MRI, CSF flow test. If the midbrain aqueducts obstructive obvious the patient, this kind of hydrocephalus, we should make a FEB shunt. If the midbrain aqueduct is fluent, we can make lumbar CSF drainage. And before and after drainage, we can examine behavior examination, such as give consciousness level assessments, the CSR score assessments, and MR. And if the patient have consciousness, we can make MSE assessments. If we decide to make a BB scan, we should the patient should have normal temperature, normal white cell count, normal CSF fluid, and the pressure assessments is very important. As pressure assessments, we should consider different strategy for this patient's PB shunt operation. So we summarized. We believe the normal ventricle size, normal brain function is the basis for the good brain function. So we treat the hydrocephalus. We are targeted to recover the patient's ventricle size to the normal size. So for the patients, for the hydrocephalus patient in disordered consciousness, we will should have the clinical evaluation in detail and seriously CT scan if the patients show the ventricle size enlarge gradually, and we should make an MRI evaluation, especially for the CSF flow test, and so we can decide we should do the operation or not. And if we want to do the operation, we should choose a different method: BB shunt or LP lumbar peritoneal shunt or the ventricular coolostomy. So then we furthermore determine. Then if we do the shunt the hydrocephalus shunt, furthermore we should determine the type of VB tube to be selected is very important. Anti-siphon or non-anti-siphon tube for the patients with the low pressure hydrocephalus or poor brain compliance, priority should be given to non-anti-siphon VB tube. Certainly, some kind of condition, not always non-anti-siphon VB tube is preferred. In the patient with the hydrocephalus combined with a large bone window, if ankle shunt surgery is performed first, the priority should be given to the anti-siphon VB tube because the atmosphere pressure is very, very important, should be considered. Then the setting of after operation, the setting of pressure level is determined by the size of the ventricle. We target it to the normal size and the best conscious level and the best neural function. So for the patient, this auto consistent with the hydrocephalus. So we have a treatment protocol. How to assessment the patients and how to select the operation method and how to select the tube, anti-silicone or no anti-silicone tube, and how to set the pressure level. And looking forward to provide help for the treatment of the patient's hydrocephalus with that disorder of consciousness. Thank you so much.
Thank you very much, Professor Wu. That's a fantastic lecture. As someone who deals with complex hydrocephalus, the time all my colleagues come to me is when they have a patient with a low pressure hydrocephalus, and whether it's a skull-based surgeons or tumor surgeons or head injury surgeons, that's when they really want someone with expertise in the hydrocephalus. But your algorithm, your logic all makes sense to me. I'm just going to invite Dr. Jallo, Dr. Caceres, Dr. El Jamal, and Dr. Schmidt. If anyone else wants to make any comments, please do so. George, can I call you in first, please? Thanks.
Yeah, no, Naren, I think that was a great presentation. I have to admit, I find this patient population the most complex to take care of. Previously, early on in my career, you'd see it, we'd put a shunt in, patients wouldn't get better, didn't really recognize the entity of low pressure hydrocephalus and the need, the complex needs that this population need, the care that they need. In general now, I will use a programmable shunt, and I will also never put an anti-siphon device in there, because that's where I've run into the problems managing these patients, especially the ones that are post-traumatic.
Thanks. Thank you, George. Dr. Caceres? You are mute, sir.
So my only take on this is that previously we were using strata valve systems, and then recently we switched to the Mifke systems, and then you can put an anti-gravitational device, which you can set. They come in fixed pressure settings, so you can actually put a 5 centimeter, which will allow the patient that once the patient is laying on his back, you can almost dial down his pressure almost to 0. But once he stands up, he will keep a minimum of 5, which prevents to a greater extent, not fully, but it does help to prevent chronic subdurals. I find this setting to be a little bit more flexible than the standard strata and Hakim systems, but that might be just my impression. I'd like to hear if someone else, or in your case, Naren, what do you think about this shunting system?
Thanks. Thank you very much, Adrian. I think I have to say that I think listening to Dr. Wu's lecture and the discussions, I think the main problem with this low pressure hydrocephalus patient is keeping the EVD going for a long time. But I now have read couple of at least one paper or two paper where they put the shunt and then, as Professor Wu said, to pump the chamber. And if you there are a few hardwares from Mithke, I have no tie-up to any companies, is that they have got a one-way reservoir. So when you press, the fluid only goes in one way. It's called the sprung reservoir. And it comes in two sizes, pediatric and adult. And so if you get a larger one, then you can push the fluid in one way. So having an EVD for a long time and getting an infection, you can put a shunt and then you push the reservoir. Another thing is that, anyone who wants to, for this niche market, produce a larger one-way reservoir so that you don't have to push it so many times. The other thing is also the important point that Professor Wu made was knowing the ICP, because once you put a shunt, you don't know what the ICP unless you put an ICP monitor. although it might seem expensive, but once again, MITK have this inline sensor reservoir where you can use a telemetry to see what the pressure is. These patients are usually long-term patients, so I think at the end of the day, the money would be well spent. So these are my thoughts. I think you are right in terms of the MITK valves. As long as you don't use the anti-gravity unit, if you just use the programmable unit, then it's easy to go from 0 to 20, or if you nowadays use that M-Blue, but that's anti-gravity, but you can use the anti-gravity. So I think if you use the programmable without the anti-gravity unit, I think that gives the MITK gives more lateral, more option than Strata or the usual Codman or Sofisa, because with the MITK you can go to 0. So these are my thoughts in the sense that you can have a shunt, put a reservoir, one-way reservoir, and have a telemetric measurement for the ICP. But this is just my thoughts. I don't know whether there are any use, Adrian, from what I have said, but these are my.
Different kinds of FEB shunts. In Medtronic, the lowest 0.5, and some kind of FEB shunt can to the 0. The 0 is good, but for low pressure hydrocephalus, because the poor brain compliance to the lowest, maybe still cannot work very well. So how to improve the brain compliance is very important. EVD can be helpful, and how to improve the brain exploration is very important. But EVD cannot for a long time because the high risk of infection. So punch the valve can be helpful. Yeah, by sometimes. Yeah.
That's great. Thanks. Sam, do you have any experience with this low pressure?
Yeah, it was a great presentation, actually. Challenging cases. Sometimes we come across a case similar to that, and we put the AVD, we drain a lot of CSF, and patient's clinical condition improves, but the ventricle size does not improve. And we reached to a conclusion that it is like a ventricular rigid or stiff wall syndrome. But the same principle, actually. It's a low pressure hydrocephalus, and when we revised the shunt, used another different type of shunt with the lower pressure, and they got better.
Thank you, Eric. How have you managed these low pressure hydrocephalus patients?
First of all, your presentation, Dr. Wu, was very interesting. And by chance, I'm also running a research project here in France and Toulouse to explore more extensively what is the connection between persistent disorder of consciousness and hydrocephalus. I got a couple of questions to address. First, if we assume that patients after a subarachnoid trauma or whatsoever spontaneously recovers in terms of consciousness, it means that usually we assume that synaptic plasticity was able to make new arrangement in order to facilitate wakefulness and recovery. But if we assume that the valve changing pressure, that's what we're doing with a shunt, actually leads to an improvement in consciousness, it means that the disorder of consciousness was barosensitive. In other words, there is an ability of the brainstem and the basal nuclei to recover after a shunt. Then my first question is, do you have any clue or any hypothesis to identify where and what sort of mechanism takes place in the brain of this patient? You've shown very interesting case, so that he or she recovers. What do you have any hypothesis, or do you think that a particular region of the brain is involved or recovers once shunted after a long period of consciousness disorder?
I don't understand you as well. You mean?
Sorry.
Professor Wu, what Dr. Schmidt is saying is that when you have got the normal low pressure hydrocephalus, the GCS is low, and when you treat it with the shunt, the GCS improves. He was wondering, where do you think the effect for the decrease in the level of consciousness? Is this possibly due to the large fourth ventricle that you mentioned, or is this do you have any thoughts as to hypothesis as to what might be the location where the main problem for the consciousness is? Is that right, Eric? Is that what you are saying?
Yes, it is. Yes, especially the hypothalamus.
Yeah, for the patient, you mean for the patients in the it's out of consciousness for a long time. How do we know the patient can improve the consciousness of the hydrocephalus? Is or not?
No, the question is, which part of the brain do you think is mostly affected by the low pressure hydrocephalus to cause the decrease in consciousness?
Usually, because in China, we have so many patients with lung disease cause in the rehabilitation hospital. These patients showed the enlargement of the hydrocephalus cause. Usually, these patients, because the brain tissue damage and the brain tissue loose, so the ventricular size enlarged. Maybe we believe have no choice to manage to treat for these patients. How to judge the patients can work well or not? So we how to assessment the diagnosis of the hydrocephalus for these patients is most important. So we assessment the CT scan and the MRI scan and make some lumbar internal drainage to assessment the conscious level and the change can be improvement. Yeah. So we make close assessments, before we make a decision. So this is very important.
Okay.
Also, maybe the patient in disorder consider have different region damage. So the MRI scan very important to assessments the different region cause the patient's the consciousness damage. This is very important. MRI scan.
Because brain imaging is definitely a very good tool, or EEG, to characterize, actually, because you very nicely showed that patients that are properly identified can improve in terms of consciousness, which is something completely different. And may I remind you that if you read the original patient, I strongly advise you to do so, to read the original paper from Hakim, described the concept of normal pressure hydrocephalus, published in 1965, among the 3 patients. That it was the seminal paper that describes the concepts of hydrocephalus and normal pressure. Among the 3, 2 were patients with post-traumatic hydrocephalus. Even the original description was patient with alertness. And what you mentioned, that's why your presentation is so important for me, because we usually assume that the patients with NPH have a gait problem, urinary incontinence, or cognitive decline. But as well, there is an alertness problem. The patient has sort of a foggy brain. And most of the time when you operate on, they sort of wake up. It means that what you're experiencing and what you're looking at is very probably what happened also in patient in NPH, in normal pressure hydrocephalus, in the older population. It's a continuous process. And that is why it is so important to spot and to conceive and experimental work to identify what are the tracks, what is the neuroanatomy involved and the neurophysiology that links stunting, irrespective of the mechanisms, and improvement of consciousness. And that absolutely fascinates me, because consciousness is clearly connected with CSF problem. But the explanation on the link between consciousness disorder and CSF problem is difficult to identify because of the variety of mechanisms, ischemia, lesional, axonal damage, whatsoever. But at the very end, in the process of the consciousness disorder, CSF problem can be a clue and it can be reversed. That's why it's so important, and I strongly encourage you to carry in this direction.
Thanks. Thank you very much. Professor Wu, do you have any comments?
Yeah. The disorders of consciousness assessments is very important. In our center, we have an EEG language stimulation, language stimulation pattern to the patient to observe their response to the language. The language, if the patient can respond to the words and to the sentence and to the different level difficult level the language, the patients have different response will be show the different prognosis. This is very interesting the topic. We have this research, this paper in 2000 in the Nature Neuroscience, and with the Chinese language stimulation.
Thank you very much. Just one point before we move to the next presentation is that, Dr. Ricketts' concept, and I think he had that seminal paper where you put a tubing grip, neck wrap to decrease the venous outflow and increase the turgor, and thereby increasing the intracranial pressure. I think it's well worth it. I think I haven't done it. I have done it on one patient, but it was not really a patient of this kind. But I think Professor Andre Grottenhuis gave me advice that when you put the tubing grip around the neck, what you need to do is that put balls of cotton buds around the internal jugular vein, so that the tubing grip actually pushes on the internal jugular vein. So that's just a tip. So thank you very much, Professor Wu. That was a fantastic and thought-provoking and very useful lecture. I'm grateful for that. So